Immunosuppressive drugs are used to prevent transplant rejection, treat autoimmune diseases, and modulate immune responses. For USMLE step 1, it's not just about knowing the drug, but knowing how it works, what cellular pathway it blocks, and what side effects or infections you need to look out for. Let's make this crystal clear. Let's start with the calcineurin inhibitors. Two of the most high yield drugs, cyclosporin and tacrolimus. Both the drugs inhibit T cell activation by blocking calcineurin, a key enzyme in the interleukin 2 signaling pathway. Cyclosporin binds cyclophilin and inhibits calcineurin. Tacrolimus binds FK506 binding protein but still ends up inhibiting calcineurin. The result? Decreased interleukin 2 transcription. So, decreased T cell activation here. These drugs are used post-transplant to prevent rejection. What is USMLE favorite here? The major side effect of both is nephrotoxicity. Cyclosporin can also cause gingival hyperplasia and hirsutism. Next up is sirolimus, also called rapamycin. It works downstream of interleukin 2. It binds FKMB but inhibits mTOR, blocking T cell proliferation. Sirolimus is especially used in kidney transplants because it is not nephrotoxic. A good way to remember this: kidney survives with sirolimus. Survives with sirolimus. Sir. Right? Then we have basiliximab, a monoclonal antibody against interleukin 2 receptor, that is CD25, on activated T cells. It is another transplant drug, less toxic, often used in induction therapy. Now to antimetabolites. First is azathioprine. It is a prodrug of 6-mercaptopurine which blocks a purine synthesis. It affects rapidly dividing cells, especially B and T cells. A classic step 1 clue: it is metabolized by xanthine oxidase, so toxicity increases when combined with allopurinol. Next is mycophenolate mofetil. This inhibits inosine monophosphate dehydrogenase, a key enzyme in guanosine synthesis used by lymphocytes. It is associated with GI upset, pancytopenia, and increased risk of CMV infection. Now, the most broadly used class, glucocorticoids. These inhibit NF-kappa B, a transcription factor for pro-inflammatory cytokines. That means decreased interleukin 2, TNF-alpha and more. Glucocorticoids causes lymphocyte apoptosis, reduces inflammation, and are used for almost every autoimmune condition. But long-term use leads to Cushingoid features, osteoporosis, hyperglycemia, and immunosuppression. Last, we have cytokine therapies. These are recombinant cytokines or monoclonal antibodies used to stimulate the immune cell production. Erythropoietin, that stimulates RBCs. GCSF, that is filgrastim. This stimulates neutrophil production. Interferon alpha, used for hepatitis B or C, melanoma. Interferon beta, used in multiple sclerosis, and interferon gamma, used in chronic granulomatous disease. Now a recap. Cyclosporin and tacrolimus, they block calcineurin, decreases interleukin 2, and remember they are nephrotoxic. Sirolimus, they block mTOR, no T cell proliferation, and kidney safe. Basiliximab, interleukin 2 receptor blockers. Azathioprine, purine synthesis blocker, and watch with allopurinol. Mycophenolate inhibits IMP dehydrogenase that decreases lymphocytes. Glucocorticoids inhibits NF-kappa B that decreases cytokines. Cytokine therapies that is used to stimulate specific cell lines or immunity. This chapter is not just pharmacology, it is immune engineering. Once you know the target, the mechanism and the effect, you are unstoppable. You have almost completed immunology. Let's keep going strong. Next up, chapter 16, infections, immunodeficiency. Stay tuned. This is Dr. Ram here from MedMadness. See you next podcast.